Okay, let's unpack this. Today, we're embarking on a truly fascinating journey into a corner of infectious diseases that often gets overshadowed, yet is absolutely brimming with surprising facts and critical insights. Our mission, should we choose to accept it, is to truly master Chapter 183 of the provided material, focusing on endemic treponematoses. You might think you know about syphilis, but what about its ancient, lesser known, and equally compelling relatives? We're talking about a family of diseases that not only blurs traditional medical understanding, but also reveals a deeper story about bacterial evolution and global health challenges. We're going to dive incredibly deep into every single detail, aiming to understand this topic like the elite professionals in the field.
Exactly. And what's fascinating here is how these seemingly distinct diseases offer a unique lens into bacterial evolution, the complexities of global health, and even how our fundamental knowledge of disease can shift over time. We'll be connecting the dots on how these cousins of syphilis impact communities worldwide and why understanding them in such granular detail is crucial for global health professionals and, well, anyone keen on truly mastering this specific area of infectious disease. It truly underscores how cunning and adaptable these microorganisms are and how much we still have to learn even about infections that have been around for centuries.
That's the perfect way to frame it. So let's kick off our deep dive into the Treponema family tree, venturing beyond the well-known venereal syphilis and into its intriguing, often neglected relatives. To begin, let's introduce these neglected infections, the endemic treponematoses. What exactly are we talking about here when we use that term?
Endemic treponematoses. Yeah, it's a bit of a mouthful, but essentially it refers to a group of chronic infections caused by a spiral-shaped bacterium called Treponema. Think of them as very close cousins to the bacteria that causes venereal syphilis. These diseases persist over a long period, and they're typically transmitted through direct person-to-person contact, often in childhood. Much like syphilis, they have this insidious quality. They can cause severe, destructive problems years, sometimes even decades, after the initial infection if left untreated. What's crucial to grasp from the outset is that these are caused by organisms that are genetically very, very similar to Treponema pallidum, subspecies pallidum, the agent of venereal syphilis. They're almost identical at a genetic level, which, as we'll see, creates a fascinating paradox.
So if they're so similar genetically, how did we historically distinguish these from venereal syphilis? What were the traditional lines doctors drew?
Well, traditionally, conditions like yaws, pinta, and what's known as endemic syphilis, also called bejel, they were separated from venereal syphilis based on a few key factors. These included their primary mode of transmission non-sexual for the endemic forms, contrasted with sexual transmission for venereal syphilis. They also looked at the typical age of acquisition, their geographic distribution, and their specific clinical features. However, and this is a critical takeaway right from the source material, overlap exists for every single one of these traditional distinguishing factors, which means those clear lines we once drew are often quite blurry in the real world of infection.
That immediately complicates things, doesn't it? It suggests our understanding might have been a bit too neat. And speaking of knowledge, how robust is our understanding of these infections, given their historical neglect?
That's a significant point, because our current knowledge about these infections is primarily based on observations made by healthcare workers who visited endemic areas over the past 70 years or so. This highlights a foundational challenge. There are historical gaps and, well, inherent difficulties in collecting comprehensive long-term data in remote or underserved regions. It means much of what we know is based on clinical observation, rather than extensive molecular or genetic studies until much more recently. It's also worth noting the general lack of recent research, with one major exception: the ongoing Mass Drug Administration, or MDA, programs for yaws eradication, which are actively promoted by the World Health Organization.
The WHO's historic mass eradication campaign for yaws. That was a massive undertaking, right? From 1952 to 1969. Tell us more about its sheer scale and the impact it had.
Indeed, it was an incredibly ambitious and large-scale initiative, really demonstrating global health cooperation at its best back then. During that period, an astonishing 160 million people were examined for treponemal infections across Africa, Asia, and South America. The sheer scale is difficult to fully grasp. Imagine coordinating that effort globally. As a direct result of these efforts, over 50 million cases and their contacts were treated, primarily with a single dose of penicillin. The campaign had a dramatic impact, successfully reducing the prevalence of active yaws from over 20% to less than 1% in many of the affected areas. It was, for its time, a remarkable public health success story that held the promise of eradication.
But then it sounds like we might have dropped the ball because the source mentions a documented resurgence. What went wrong after such an impressive initial success?
Precisely. Unfortunately, in the subsequent decades, there was a significant lack of focused surveillance and a diversion of resources away from these crucial programs. This led directly to documented resurgences of these infections in some regions. It's a classic cautionary tale in public health. Initial success needs sustained, long-term effort and vigilance to truly achieve elimination. Otherwise, well, the gains can quickly be lost.
And what's the current global landscape looking like for these diseases based on the most recent data available from around 2018? Where are we seeing them most prominently and where are the challenges still significant?
The picture is mixed, and comprehensive data can still be scarce for some regions. That's part of the problem. For yaws, specifically, in 2018, there were 15 countries reporting current cases, and an additional 3 countries with suspected cases. A total of 80,472 suspected cases were reported globally, primarily in areas where active yaws detection and treatment trials are ongoing. In Africa, we've seen resurgent yaws morbidity in countries like Ivory Coast, Ghana, Togo, Benin, the Central African Republic, Nigeria, and the Democratic Republic of the Congo. As for endemic syphilis, or bejel, its estimated prevalence is over 10% in parts of northern Ghana, Mali, Niger, Burkina Faso, and Senegal, though the data for this is admittedly scarcer than for yaws, making it harder to track with precision. Looking east, in Asia and the Pacific Islands, active yaws outbreaks have been documented in Vanuatu.
But amidst these challenges, there's also a real beacon of hope, isn't there? A major success story in India.
Oh, absolutely. A truly inspiring one, demonstrating what dedicated, sustained effort can achieve. India actively renewed its focus on yaws control in 1996. Their systematic and sustained efforts led to achieving zero-case status in 2003. They declared elimination in 2006 and were finally declared yaws-free in 2016. This provides a powerful model for other countries and underscores that eradication is possible with the right commitment. In the Americas, suspected yaws cases have been reported in Haiti, Colombia, and Ecuador. However, for countries like Peru, Brazil, Guyana, Suriname, and many Caribbean islands, recent data is insufficient, so the true current status of yaws remains unclear in many parts of the region. And then there's pinta, which is thought to be much more geographically limited, found primarily in Central America and Northern South America, and even there, it's rare and only seen in very remote villages, making it almost an outlier in this family.
That's a comprehensive global snapshot. Now, this next point is absolutely fascinating and adds a layer of complexity. The question of an animal reservoir. We're talking about wild, non-human primates here. What's the connection, and why does it matter so much?
This is an area of intense ongoing research and significant interest because it could fundamentally impact eradication efforts you see. Researchers have found yaws-like and even genital lesions, coupled with treponemal seroreactivity, meaning the animals show antibodies indicating past or present infection, in several species of wild non-human primates, specifically in sub-Saharan Africa. What makes this particularly compelling is that organisms very closely related at the genomic level to T. pallidum subspecies pertinu, the exact bacterium that causes human yaws, have been identified in these affected non-human primates. So we're seeing human yaws genetic fingerprint in wild monkeys. However, it's crucial to emphasize that direct non-human primate-to-human transmission has not yet been confirmed. This is a critical knowledge gap because if an animal reservoir exists and can continually reinfect humans, it poses a fundamental challenge to global eradication efforts. You could treat every human case, but if the infection can jump back from animals, you're fighting an uphill battle. It's a huge, unresolved piece of the eradication puzzle.
Okay, let's unpack this further because this is where it gets really interesting and illustrates the nuances of these infections. We've introduced the family, now let's get up close with these treponemal cousins by diving into a comparative table. This is where we see the nuances that traditionally set these infections apart and, importantly, where those lines are blurring, forcing us to rethink old assumptions. So let's go through each organism and its key features, essentially comparing their unique identities.
Absolutely. When we look at Table 183-1, it lays out the crucial distinctions and similarities that define this family. First, let's identify the organisms, because even within the Treponema pallidum species, there are distinct subspecies. For venereal syphilis, it's Treponema pallidum subspecies pallidum. For yaws, it's Treponema pallidum subspecies pertinu. For endemic syphilis, also known as bejel, it's Treponema pallidum subspecies endemicum. And for pinta, it's Treponema coradium. It's important to note that T. coradium remains a separate species in classification simply because, to date, no viable organisms have been available for detailed genetic studies, which means we can't fully compare its genetic blueprint with the others.
That's a key distinction right there, a classification based on lack of data. Now let's talk about transmission, which is one of those traditional differentiators that, as you mentioned, is becoming less clear-cut.
Right. For venereal syphilis, the common modes of transmission are sexual contact and transplacental, meaning from mother to fetus during pregnancy. Yaws is primarily spread by direct skin-to-skin contact, often through casual touch or play. Endemic syphilis was traditionally thought to be transmitted mouth to mouth or through shared drinking and eating utensils within a household. However, and this is the crucial update from recent findings that radically shift our understanding, sexual transmission for endemic syphilis has recently been observed and postulated in certain settings, specifically noted in Paris, Cuba, and Japan. This directly challenges the classic non-venereal classification. It means clinicians need to be much more aware of how these diseases can present outside of their traditional modes. Finally, pinta is also transmitted skin to skin, similar to yaws.
And the age of acquisition, another traditional distinguishing factor, how does that compare across the family?
For venereal syphilis, it's typically acquired at sexual maturity or in utero. Yaws is commonly acquired in early childhood, often affecting young children playing together. Endemic syphilis, while historically also acquired in early childhood, has recently been observed to be acquired in adulthood as well, further blurring the lines with venereal syphilis and suggesting a shift in its epidemiological pattern. Pinta is typically acquired slightly later, in late childhood.
What about the primary lesion, the first sign of infection, and its common location? How do they differ?
The primary lesion for venereal syphilis is usually a cutaneous ulcer, often called a chancre, and it's typically found on genital, oral, or anal areas. In yaws, it's a papilloma, a sort of wart-like growth which is often ulcerative, meaning it can break open and bleed, and is typically found on the extremities. For endemic syphilis, it's a mucosal papule, a small bump inside the mouth, which is rarely seen because of its location and subtle nature. Pinta, distinctively, presents as a non-ulcerating papule with smaller satellite lesions around it. It's often pruritic or itchy and located on the extremities or face.
And the secondary lesions, those widespread effects after the initial infection has progressed.
In venereal syphilis, you commonly see a generalized cutaneous rash, mucocutaneous lesions, which are lesions affecting both skin and mucous membranes, and condylomata, which are moist, wart-like lesions often found in warm, moist areas of the body. Yaws presents with cutaneous papillomatous or ulcerative lesions similar to the primary, along with condylomata and osteoperiosteitis, which is inflammation of the bone and its surrounding membrane, causing deep pain. Endemic syphilis also has mucocutaneous lesions, such as mucus patches in the mouth, split papules, and condylomata, along with osteoperiosteitis. Pinta distinctively shows what are called pintides, which are highly pigmented, discolored spots on the skin and are also pruritic.
Are infectious relapses common across all of them? Do they tend to come back?
They're quite common for yaws, yeah, and they occur in about 25% of venereal syphilis cases. For endemic syphilis and pinta, the frequency of infectious relapses or how often the active disease reemerges is currently unknown due to limited research.
Finally, the late complications. These can be quite severe and destructive for some of these diseases.
This is where some of the most profound differences lie. Venereal syphilis can lead to gummas, these soft, non-cancerous growths that can affect almost any organ, as well as serious cardiovascular and central nervous system involvement. Both yaws and endemic syphilis can also cause destructive gummas of the skin, bone, and cartilage. A particularly devastating manifestation seen in both is gangosa, which involves extensive disfiguring destruction of the nose, maxilla, palate, and pharynx. It's a truly horrific outcome. In stark contrast, pinta's late complications are entirely non-destructive. They are characterized by dyschromic or discolored anachromic or unpigmented macules, flat spots on the skin, which merely change skin color without causing tissue damage. This is a profound difference, as pinta doesn't cause the severe tissue destruction seen in the others. What's fascinating here is how the source material also notes the recent postulate of sexual transmission for endemic syphilis and acquisition in adulthood, which directly challenges the traditional non-venereal classification and means clinicians need to be much more aware of how these diseases can present. And then there's the critical mention that some investigators postulate CNS involvement and congenital infection in endemic treponematoses, which is a major reevaluation of long-held beliefs and something we'll dive into more deeply later because it has massive public health implications.
That table truly highlights how closely related yet clinically distinct these organisms can be. It's like finding two identical twins, but one only ever gets a runny nose, and the other develops serious lifelong conditions. This tells us that even minuscule genetic differences can have profound real-world impacts on disease. But let's push this further into what's known as the one organism controversy. If they're so genetically similar, what truly makes them distinct diseases? Or are they not?
This is the crux of a major debate in microbiology and infectious disease, really. The core information is that the bacteria causing all these endemic treponematoses are morphologically identical. They look exactly the same under a microscope to T. pallidum subspecies pallidum, the bacterium that causes venereal syphilis. And to date, no definitive antigenic differences, meaning differences in the proteins that the immune system recognizes and attacks, have been identified among them. This has led to a long-standing historical controversy. Are these pathogenic treponemes truly separate, distinct organisms, or are they just different clinical expressions, different flavors, if you will, of essentially the same bacterium influenced by environmental factors or specific host responses?
So, what does the genomic evidence, the actual blueprint of these organisms, tell us? That's where we get down to the absolute fundamental truth, right?
Right. Genomic sequencing has provided compelling and often surprising insights. It reveals that the treponemes causing yaws, bejel, and syphilis are an astonishing 99.8% identical at the genetic level. Think about that for a moment. Less than 0.25% difference in their entire genetic code. Several studies further support the ability of these pathogens to exchange DNA between subspecies, which is incredibly significant because it suggests a high degree of evolutionary fluidity and adaptation. Because of these findings, 3 of the 4 agents are now classified as subspecies of Treponema pallidum. As mentioned earlier, T. caradium, the agent of pinta, remains a separate species only because no viable organisms have been available for comprehensive genetic studies, a critical missing piece of the puzzle.
Even with that near identical genomic blueprint, are there any subtle molecular signatures that can help us tell them apart in a lab, despite the macroscopic similarities?
Yes, molecular typing methods have been developed. These techniques, ranging from older methods like restriction fragment length polymorphism to the cutting-edge whole genome sequencing, have identified specific genetic signatures that can differentiate the T. pallidum subspecies. However, these methods are based on the analysis of a limited number of strains in clinical samples, so they represent an initial step, not a complete picture. A crucial, overarching, unanswered question is whether these minute genetic differences, that less than 0.2% variation, are directly responsible for the distinct clinical characteristics we observe in these diseases. That direct cause-and-effect link has not yet been definitively determined. It's a key area of ongoing research.
And the baboon connection again, the Friedberg-Blanc strain, how does that fit into this genomic puzzle, and what does it tell us about the potential for an animal reservoir?
The full genome sequencing of the Friedberg-Blanc treponema strain, which was originally isolated from a baboon back in 1966, shows a very high degree of homology, meaning genetic similarity with available strains of T. pallidum subspecies pertinu, the human yaws bacterium. Furthermore, recent genomic analyses of additional samples from non-human primates continue to indicate a very close genetic relationship with known human yaws isolates. This raises an important question. If these organisms are so genetically similar and present in non-human primates, what truly makes them distinct diseases in humans? The ability to exchange DNA between subspecies is fascinating and has profound implications for how these bacteria evolve and adapt, potentially jumping between hosts. Understanding this animal reservoir is absolutely critical for global eradication efforts, because if humans can be continuously reinfected from non-human sources, then treating human cases alone might not be enough to truly eliminate the disease. It's a huge piece of the puzzle we're still trying to solve, and one that could make eradication significantly more complex than initially thought.
So, we've explored the family tree and the genetic ties, revealing surprising similarities. Now let's unpack the clinical pictures of these diseases. Despite their deep genetic closeness, they have some quite unique, sometimes horrifying manifestations, don't they?
They absolutely do, and this is where the mystery deepens. All treponemal infections, including venereal syphilis, are chronic, and they share a general progression characterized by defined disease stages. Typically a localized primary lesion, followed by disseminated secondary lesions, periods where the infection is latent or silent, and then the potential for severe late lesions. However, there are key differences in their progression. The primary and secondary stages are more frequently overlapping in yaws and endemic syphilis compared to venereal syphilis. This means you might see both the initial sore and widespread skin issues appearing at the same time, making it hard to pinpoint an exact stage. And, as we touched on earlier, the late manifestations of pinta are very mild relative to the highly destructive lesions seen in the other treponematoses. Given these clinical differences, the current preference in the medical community is to simply divide the clinical course of the endemic treponematosis into early and late stages, rather than trying to fit them into the more rigid three-stage primary, secondary, and tertiary model often used for syphilis.
Let's zoom in on yaws first, sometimes called framboisia because of its raspberry-like lesions. Tell us more about its progression and the specific visual signs we might see.
Right, yaws is also known by names like peon or buba. Its early stages are characterized by the development of one or several primary lesions, often called the mother yaw. This is typically a raised, often ulcerated growth that looks a bit like a raspberry, hence the name framboisia. This primary lesion is then followed by multiple disseminated skin lesions spreading across the body. All of these early skin lesions are highly infectious and can persist for many months, making person-to-person transmission quite efficient. Cutaneous relapses, where the skin lesions reappear after seemingly healing, are quite common during the first 5 years of infection. Later on, affecting approximately 10% of untreated persons, yaws can lead to destructive lesions of the skin, bone, and joints, which can be profoundly debilitating.
How exactly is yaws transmitted in these endemic regions? Is it purely direct contact, or are there other factors at play?
It's primarily by direct contact with those infectious lesions, often occurring during play among children or even group sleeping arrangements. Imagine children playing together and one has an open sore. The bacteria can easily transfer. Transmission may be enhanced by any disruption of the skin, such as insect bites or abrasions, which can provide an entry point for the bacteria. Now, there's been some intriguing research and even controversy around indirect transmission. T. pallidum subspecies pertinu DNA has been detected on flies and fomites-like contaminated objects or shared items from endemic regions. However, it's important to state that there is not yet convincing evidence of insect or fomite transmission actually causing infection in humans. It's a potential route that scientists are still investigating, but it's not confirmed as a significant mode of spread.
And what does the lesion development look like in detail, from the initial contact to the secondary eruption? Give us a clearer picture.
Okay. After an average incubation period of about 3 to 4 weeks, the first lesion, that primary mother yaw, begins as a papule, typically on an extremity. This papule then enlarges, especially during moist, warm weather, and can become ulcerated like an open sore or develop that characteristic papillamatous raspberry-like appearance. What's also notable and significant from recent data is that a large proportion of ulcerative lesions found in yaws endemic regions contain Haemophilus ducreae, another bacterium known for causing skin ulcers, either as the sole cause of the ulcer or in combination with T. pallidum subspecies pertinu. Interestingly, H. ducreae DNA has also been detected on flies and fomites, just like the yaws bacterium, which opens up more questions about co-infection and transmission pathways. As the primary lesion develops, regional lymphadenopathy, or swollen lymph nodes in the area, occurs. The primary lesion usually heals within 6 months, and the dissemination of the bacteria throughout the body is thought to occur during the early weeks of infection. Following this, a generalized secondary eruption, often accompanied by widespread lymphadenopathy, appears either concurrently with or after the primary lesion. This secondary eruption can take various forms: macular, papular, or papillomatous, and these lesions may also become secondarily infected with other bacteria, including H. ducreae.
You mentioned some specific clinical signs earlier, like crab yaws. Can you elaborate on those and how they affect individuals?
Yes, crab yaws are particularly painful papillomatous lesions that develop on the soles of the feet. They are so debilitating that they result in a characteristic, shuffling, crab-like gait, making movement very difficult and painful. Additionally, periostitis, which is inflammation of the membrane surrounding the bone, can occur. This can lead to significant nocturnal bone pain, often waking patients up at night, and polydactylitis, which is inflammation and swelling of multiple digits, fingers, or toes. These are not minor discomforts. They can severely impact a child's ability to play, attend school, or an adult's ability to work.
In the late-stage yaws, how severe does it truly get? What are the long-term destructive consequences?
Late yaws is characterized by severe and extensive manifestations, a stark contrast to the initial skin lesions. You see skin and bone gummas, those destructive soft growths, hyperkeratosis, which are thickened, hardened areas of skin, especially on the palms and soles, osteitis and periostitis, inflammation of bone and its lining, and hydroarthrosis, which is fluid accumulation in the joints. The late gummatous lesions are typically extensive and highly destructive, disfiguring parts of the body. A particularly devastating manifestation is gungosa, a term that describes severe destruction of the nose, maxilla, palate, and pharynx. Imagine the face being eaten away, It's a truly horrific outcome, similar to severe lesions seen in other neglected tropical diseases like leprosy and leishmaniasis. These are the life-altering consequences of untreated yaws.
Moving to endemic syphilis or bejel, this one also goes by many local names. What are its defining characteristics, especially in terms of early lesions and how it spreads?
Right, endemic syphilis, also known by names such as bejel, CD, dichuchua, ingevera, or scarlievo, primarily presents with early lesions localized to mucocutaneous and mucosal surfaces, meaning the skin and the moist linings of the body, especially the mouth. Historically, it was reported to be transmitted by direct contact, often through intimate family activities like kissing, the premastication of food for infants by a parent, or the sharing of drinking and eating utensils within a household, particularly among children in crowded living conditions. However, this traditional understanding of transmission has been challenged significantly, and this is a crucial piece of modern insight. Crucially, Treponema pallidum subspecies endemicum has recently been identified in genital lesions, which were assumed to be chancres, and in secondary lesions in various contemporary settings like Paris, Cuba, and Japan. This strongly suggests that sexual transmission of endemic syphilis is occurring, which is a major departure from its traditional classification as a strictly non-venereal disease. It means we might be seeing an evolution in how this ancient disease is spreading, potentially adapting to new environments and behaviors.
How do these lesions progress from the initial contact to later stages, particularly focusing on those oral manifestations?
The initial lesion in endemic syphilis is usually an intraoral papule, a small bump inside the mouth. This primary lesion often goes unrecognized because of its location and subtle nature, sometimes described as a split papule in the corner of the mouth. This is then followed by the appearance of mucus patches on the oral mucosa, which are whitish, painless, often oval lesions, and mucocutaneous lesions that closely resemble the condylomata lata seen in secondary venereal syphilis. This eruption can persist for months or even years, making the individual infectious for a prolonged period, and treponems are readily demonstrable in these early infectious lesions, meaning the bacteria can be easily found and identified by microscopy. Other early manifestations commonly include periostitis and regional lymphadenopathy, just like in yaws. After a variable period of latency, much like other treponemal infections, late manifestations may appear, including osseous and cutaneous gummas. And it's noted that destructive gummas, osteitis and gangosa, that severe destruction of facial structures, are even more common and severe in endemic syphilis than they are in yaws. So while often starting subtly, its late-stage impact can be devastating.
Now, pinta. This one always seems to be described as the most benign of the treponemal infections, more of a cosmetic issue than a destructive one. Is that truly accurate?
Yes, that's generally accurate, and it's a key distinguishing feature. Pinta, also known as maldo pinto, karate, azul, or puru puru, is indeed described as the most benign of the treponemal infections. A key distinction of pinta is that it does not appear to cause destructive lesions or to involve tissues other than the skin. This sets it apart significantly from yaws and endemic syphilis, which can lead to severe tissue damage and disfigurement. The disease has 3 distinct stages, each characterized by marked changes in skin color, giving it a chameleon-like quality.
And what are these stages of skin changes like, from the initial lesion to the striking late-stage appearance?
The initial lesion is a papule, most often located on the extremities or the face, and it's notably pruritic or itchy. This is the primary pintid. After anywhere from 1 to many months of infection, numerous disseminated secondary lesions begin to appear. These are also called pintides, but they are widespread. These lesions are initially red, but they gradually become deeply pigmented, taking on a distinct dark slate blue color over time. These secondary lesions are infectious, highly pruritic, and can persist for years, making them a visible and often bothersome aspect of the disease. The late lesions, known as dyschromic macules, are pigmented areas that still contain tropondros. Over time, most of these pigmented lesions show varying degrees of depigmentation, first turning brown and eventually becoming strikingly white, giving the skin a mottled, patchy, almost vitiligo-like appearance. These white or chromic lesions are highly characteristic of the late stage of pinta, leaving a permanent mark, but crucially without the tissue destruction seen in its cousins.
So what does this all mean when we piece together the clinical picture with the genetic similarities? We've seen these diseases often have destructive impacts, but a long-held belief was that they didn't affect the central nervous system, the brain, and spinal cord, or pass from mother to child. Is that truly accurate? Because the source seems to fundamentally challenge this distinction, which would be a huge revelation.
This is a truly paradigm-shifting insight presented in the source, demanding a critical reevaluation of long-held assumptions. Historically, a major clinical distinction made between venereal syphilis and the non-venereal infections like yaws and endemic syphilis was the apparent lack of central nervous system involvement and congenital infection, meaning transmission from mother to child during pregnancy, in these non-venereal forms. However, the source material explicitly questions whether these distinctions are entirely accurate.
From a purely biological standpoint, does it even make sense that they wouldn't cause CNS or congenital issues given how incredibly similar they are at the genetic level to venereal syphilis, which does cause these severe forms?
Biologically, there's very little reason to assume they wouldn't. You're right.
Hmm.
Due to the high degree of genetic relatedness among these organisms, remember that 99.8% identity, there is little biological basis to think that T. pallidum subspecies endemicum and T. pallidum subspecies pertinu would be unable to cross the blood-brain barrier into the CNS or to invade the placenta and infect a fetus. These organisms, much like T. pallidum subspecies pallidum, clearly disseminate throughout the body from the site of initial infection and are known to persist for decades within the host. So the inherent capacity for systemic involvement, including these severe complications, is certainly there.
If that's the case, why has congenital infection been largely unrecognized or at least underrecognized for so long? Why haven't we seen more cases?
Well, the apparent lack of recognized congenital infection may be due to a specific epidemiological factor. Childhood infections often reach the latent stage, meaning a low bacterial load, and often asymptomatic, before girls reach sexual maturity. This reduced bacterial burden, combined with the immune response developed during childhood, might then lower the likelihood of fetal infection during pregnancy, making congenital cases less frequent, or, if they occur, perhaps less severe and therefore less likely to be recognized and diagnosed as such.
And what about neurologic involvement? Why would the impact on the brain and spinal cord go unrecognized for so long if the potential is there?
Several factors could contribute to that, particularly in the regions where these diseases are endemic. One is the pervasive lack of trained medical personnel and advanced diagnostic capabilities in many of the remote, often underserved regions where these diseases thrive. If there aren't clinicians actively looking for these specific, often subtle, neurological manifestations, they simply won't be diagnosed. Another is the significant delay, often many years, sometimes decades, between the initial infection, typically acquired in childhood, and the possible appearance of any CNS manifestations, which would occur in adulthood. This makes establishing a direct link incredibly difficult. Finally, it could simply be a low rate of symptomatic CNS disease, meaning while the bacteria might be present in the nervous system, they don't always cause obvious debilitating neurological symptoms that get noticed.
But is there any concrete evidence now, even if limited, to support that these distinctions are being challenged? What are researchers finding?
Yes, there is. Some published evidence, though often from smaller studies, does support the occurrence of congenital transmission, as well as cardiovascular, ophthalmologic, and central nervous system involvement in yaws and endemic syphilis. However, it's also important to acknowledge the critiques of these studies. They have often been small in scale, sometimes fail to adequately control for other potential causes of CNS abnormalities, and in certain instances, they haven't included definitive serologic confirmation. Despite these limitations, the source makes a very strong, almost defiant statement, emphasizing that it may be erroneous to accept unquestioningly the frequently repeated belief that these organisms fail to cause such manifestations. This really urges us as professionals to fundamentally reconsider these long-held assumptions and to actively look for these complications.
That's a profound, almost revolutionary implication for public health. If these benign distinctions are indeed false, if these ancient diseases can silently affect the brain or pass to newborns, how does this impact public health strategies, screening, and treatment guidelines for these diseases moving forward? This insight is a game changer.
The implications are immense, truly a paradigm shift. If these organisms can cause congenital infection or affect the CNS, it means our current screening protocols, particularly for pregnant women in endemic areas, might be woefully inadequate. It would necessitate active screening programs for expectant mothers and potentially broader newborn screening to prevent congenital cases, which can have devastating lifelong effects on children, from developmental delays to blindness or deafness. For treatment, if CNS involvement is possible, then current treatment regimens might need to be reevaluated to ensure adequate penetration of antibiotics into the central nervous system, similar to how neurosyphilis is treated, which often involves higher doses or different types of penicillin and more intensive prolonged follow-up. Furthermore, it completely changes our understanding of the true burden of disease and the overall severity of these neglected infections, making their eradication even more urgent. It completely reshapes our perception of their benign nature, revealing them to be potentially far more insidious than previously thought. This is not just a public health challenge. It's a fundamental reevaluation of medical dogma, demanding immediate and aggressive action and a complete rethinking of our approach.
This brings us to diagnosis, which sounds like a real challenge given the serologic overlap you've described. It's almost like a medical masquerade, where all the treponemal infections look identical on standard blood tests. How do clinicians navigate that?
That's an excellent way to put it, a perfect metaphor. The diagnosis of endemic treponematoses relies on a combination of careful clinical manifestations, what the lesions look like and where they are, and when available, dark field microscopy, which allows direct visualization of the spiral-shaped bacteria, or spirituotes, from a lesion sample. Then there's serologic testing, which measures antibodies in the blood. But here's the key diagnostic limitation, the heart of the masquerade. The same standard serologic tests that are used for venereal syphilis, primarily the VDRL and RPR tests, become reactive during all treponemal infections. To date, there is simply no antibody test that can discriminate among the different treponemal infections. So you can tell someone has a treponemal infection, but not which one, yaws, bejel, pinta, or venereal syphilis, from standard blood tests alone. This means clinicians must rely heavily on patient history, geographic origin, and careful clinical presentation to differentiate. If you have a person who has emigrated from an endemic area and they have a reactive syphilis serology, the non-venereal treponemal infections must be seriously considered in their evaluation because it might not be the venereal form. While advanced tools like sensitive polymerase chain reaction, or PCR, methods are available for identifying the specific etiologic agent by detecting its unique DNA, these are primarily used in research laboratories and are not widely available for routine clinical diagnosis in the field where these diseases are most prevalent. This truly hampers targeted public health interventions.
That's a significant hurdle for effective control, requiring a lot of clinical acumen. Let's talk treatment paradigms. We've heard a lot about penicillin as a traditional treatment, but also azithromycin and the emerging concern of antibiotic resistance. What's the current recommended approach?
For both patients and their close contacts, the current World Health Organization recommended therapy includes either a single oral dose of azithromycin, specifically 30 milligrams per kilogram of body weight, up to a maximum of 2 grams, or an intramuscular injection of benzathine penicillin G. The dose for adults is 1.2 million units, and for children under 10 years old, it's 600,000 units. A recent study demonstrated that these two drugs are equivalent in their efficacy, which is a major breakthrough, particularly for mass treatment campaigns. The ability to use an oral pill instead of an injection revolutionized the logistics.
So the azithromycin seems like a game changer for mass treatment, making it much easier to deploy. But what about the penicillin dosage nuance? It sounds like there's a specific detail to be aware of.
Indeed, the recommended dose of benzathine penicillin G for endemic treponematoses is actually half of that recommended for early venereal syphilis. This is a critical nuance for clinicians, but it comes with a significant caveat. No controlled efficacy studies have actually been conducted for this reduced dose, specifically in the context of endemic treponematoses. It's based more on historical practice than rigorous modern trials. While there's no current evidence of genetic resistance to penicillin in these organisms, there have been reports of relapsing lesions after penicillin treatment in Papua New Guinea, which warrants ongoing observation and reminds us that these bacteria can be tricky.
And the single-dose azithromycin, that really streamlined the WHO's eradication program, didn't it? It must have made the idea of global eradication seem much more attainable.
It absolutely did. The efficacy of single-dose oral azithromycin provided the WHO's revitalized yaws eradication program with a much easier regimen for mass treatment. Imagine the logistical difference between giving an injection to millions of people in remote villages versus simply giving them a single pill. It made the prospect of global eradication much more feasible and cost-effective. However, this convenience comes with a significant and growing concern: emerging macrolide resistance. Macrolide resistance has already become common in circulating strains of key pallidum subspecies pallidum, that's the venereal syphilis bacterium, in many parts of the world. And critically, analysis of yaws samples from Papua New Guinea has already yielded evidence of mutations for resistance to macrolide antibiotics, including azithromycin, albeit in a small number of patients so far. This means further surveillance is absolutely essential to monitor this emerging resistance, as it could severely undermine eradication efforts. The bacteria are adapting faster than we'd like.
What about other treatment options if penicillin or azithromycin aren't suitable, perhaps due to allergies?
Data is limited here. While some data suggest the efficacy of tetracycline for the treatment of yaws, there's no comparable data for the other endemic treponematoses. However, based solely on decades of experience with venereal syphilis, it is thought that doxycycline or tetracycline, at doses appropriate for syphilis, could serve as alternatives for patients who are allergic to penicillin. It's an educated inference, but not as robustly proven for these specific endemic forms.
Let's discuss the Jarisch-Herxheimer reaction. This sounds dramatic, but it's not necessarily a bad sign. In fact, it's often a sign that the treatment is working. What exactly is happening in the body?
It can be quite dramatic for patients, yes, but as you said, it's generally a sign that the treatment is working by rapidly killing the bacteria. This is a self-limited reaction, meaning it resolves on its own, that may follow the initiation of treatment for both syphilis and the endemic treponematosis. It typically consists of a constellation of symptoms: fever, chills, muscle aches, headache, rapid heart rate, increased respiratory rate, an elevated circulating neutrophil count, a type of white blood cell, and vasodilation with mild hypotension, meaning blood vessel widening, and a slight drop in blood pressure. The reaction is thought to be a direct immune response to lipoproteins that are released by the dying T. pallidum organisms as they are rapidly killed off by the antibiotic. It's essentially your body reacting to the sudden rush of bacterial debris. It occurs in about 50% of patients with primary syphilis, a higher 90% of those with secondary syphilis, and a lower proportion in persons with later-stage disease. Typically, the fever reduction, or defervescence, takes place within 12 to 24 hours.
In secondary syphilis, you might also see an increase in erythema and edema, or redness and swelling, of the cutaneous lesions. It's crucial that patients are warned to expect such developments so they don't panic or stop treatment. These symptoms can be managed with symptom-based treatment, like fever reducers, and crucially, steroid therapy is not required for this mild, transient reaction, which is important to know in resource-limited settings.
Okay, so treatment is initiated and the Jarisch-Herxheimer reaction might occur. What's the follow-up and monitoring process like for these complex infections? It sounds like a long road to seronegativity, meaning getting those antibody tests back to normal.
It absolutely is a long and intricate road, revealing the persistent nature of these bacteria and the body's slow immune response. The efficacy of treatment should always be assessed by careful clinical evaluation, looking for resolution of lesions and symptoms, and by monitoring the quantitative VDRL or RPR titer. These are blood tests that measure the level or titer of nonspecific antibodies your body produces in response to the infection. What we look for is a fourfold decline in the titer. For example, from a ratio of 1.32 dropping to 1.8, which indicates a successful response to therapy. The follow-up schedules are quite specific. Patients with primary or secondary syphilis should be examined at 6 and 12 months after treatment, while persons with latent or late syphilis require longer follow-up at 6, 12, and 24 months. For patients concurrently infected with HIV, a more frequent clinical and serologic examination schedule is recommended, specifically at 3, 6, 9, 12, and 24 months, regardless of the stage of syphilis. This is because HIV co-infection complicates the immune response and can affect treatment outcomes.
How quickly do these serologic titers typically decline after successful treatment, and how does HIV co-infection complicate that process?
After successful treatment of a seropositive first episode primary or secondary syphilis, the VDRL or RPR titer progressively declines. The test typically becomes non-reactive by 12 months in 40% to 75% of seropositive primary cases and in 20% to 40% of secondary cases. However, in patients with HIV infection or a history of prior syphilis, these VDRL and RPR tests are less likely to become non-reactive as quickly, or sometimes at all. The rates of decline of serologic titers appear to be slower, and serologically defined treatment failures, where the antibody levels don't drop as expected, are more common among HIV-infected patients compared to those without HIV co-infection. The good news here is that effective antiretroviral therapy, or ART for HIV, may actually reduce these differences, highlighting the importance of managing HIV effectively in co-infected individuals.
And when do you consider retreatment? Is it always clear if it's a treatment failure or if the person has simply been reinfected? That sounds like a diagnostic dilemma.
Retreatment should certainly be considered if serologic responses are not adequate, meaning the titers aren't dropping as expected, or if clinical signs persist or recur. However, differentiating true treatment failure from a new reinfection is indeed very difficult, a real diagnostic dilemma. In such cases, a cerebrospinal fluid, or CSF, examination, a sample from the fluid around your brain and spinal cord, should be performed. If the CSF is abnormal, indicating CNS involvement, the patient should be treated for neurosyphilis, a more intensive regimen. If the CSF is normal, treatment for latent syphilis is appropriate. It's also worth noting that a minority of patients treated for early syphilis might experience a 1 dilution titer increase within 14 days after treatment, for example, going from 1.8 to 1.16 before dropping again. However, this early transient elevation does not significantly affect the overall serologic outcome at 6 months after treatment, so it's not a cause for immediate alarm. For patients treated for latent syphilis, they frequently have low initial VDRL or RPR titers and may not achieve a 4-fold decline after therapy with penicillin.
In these specific patients, retreatment is not warranted unless the titer rises or new signs and symptoms of syphilis appear. This is an important nuance to avoid unnecessary retreatment. Also, it's critical to remember that treponemal tests, such as TPPA or FTA-ABS, which detect specific antibodies against the bacterium, may remain reactive indefinitely despite successful treatment for seropositive syphilis. Therefore, these tests are not useful in following the response to therapy. They only tell you if a person has ever been exposed, not if the infection is currently active or successfully treated.
And specifically for neurosyphilis, the most severe form involving the brain and spinal cord, how is follow-up different? What are the key indicators of successful treatment there?
For neurosyphilis, whether symptomatic or asymptomatic, the activity correlates best with CSF pleocytosis, which is an elevated white blood cell count in the spinal fluid. This measure provides the most sensitive index of response to treatment, as it directly reflects the inflammation caused by the bacteria in the central nervous system. Repeat CSF examination is recommended 6 months after treatment for symptomatic neurosyphilis and 12 to 24 months for asymptomatic neurosyphilis in adequately treated HIV-uninfected patients. In HIV-infected patients, the persistence of mild pleocytosis in CSF may be due to the presence of HIV itself in the CSF, which can make it difficult to distinguish from actual treatment failure, a truly complex clinical situation. Elevated levels of CSF protein, another indicator, fall more slowly, and the CSF VDRL titer, which directly measures antibodies in the spinal fluid, declines gradually over several years.
Interestingly, in patients treated for neurosyphilis, a 4-fold reduction in serum RPR titer has been positively correlated with the normalization of CSF abnormalities. And this correlation is stronger in HIV-uninfected patients and in HIV-infected patients receiving effective RT, again highlighting how effective HIV treatment can improve syphilis outcomes.
That's incredibly detailed and truly shows the complexity. Now let's talk about immunity to syphilis. Does natural infection confer lasting protection, and what are we learning about how the body actually fights these infections and how that might lead to a vaccine?
The development of acquired resistance or immunity to T. pallidum after natural or experimental infection depends on both the size of the infecting inoculum, how much bacteria you're initially exposed to, and the duration of the infection before treatment. Both humoral immunity, which involves antibodies produced by B cells, and cellular responses, involving T lymphocytes and macrophages, are crucial in the healing of early lesions. Specifically, cellular infiltration, predominantly by T lymphocytes and macrophages, produces an interferon gamma-dominated cytokine milieu. Think of this as your immune system creating a specific chemical battleground, an environment that results in the clearance of organisms by activated macrophages, which are immune cells that essentially eat the bacteria. Specific antibodies to surface antigens of the bacteria further enhance this phagocytosis, making the eating more efficient. What's fascinating is the concept of antigenic variation. The TPRK protein, a specific protein in the bacteria, can change its antigens. This variation contributes significantly to the development of subsequent stages of syphilis, allows for the persistence of infection within the body, and importantly, leads to susceptibility to reinfection with another strain. This genetic shape-shifting makes developing a vaccine particularly challenging. However, comparative genomic studies have revealed other genes with sequence variations among T. pallidum strains, which has led to the development of molecular typing methods used to examine syphilis outbreaks, helping epidemiologists track the spread of specific strains like detectives. And on the vaccine front, which is crucial for future control, recent work has demonstrated that immunization with the outer membrane protein TP0751 significantly reduces the dissemination of T. pallidum during syphilis infection in an animal model. Vaccine studies with this and other antigens are currently underway, offering hope for future prevention, though it's a long and challenging road.
If we connect this to the bigger picture, the follow-up process and the discussion of immunity truly reveal how complex these infections are, especially with co-infections like HIV. It's not a simple cure and forget scenario. It's a long-term commitment to monitoring the body's response, which is a testament to the persistent and adaptable nature of these bacteria. The level of vigilance required is intense.
Exactly. It highlights the profound need for sustained public health infrastructure and robust patient education, especially in resource-limited settings where these diseases are most prevalent. The nuances of serology, the intricate impact of HIV, and the slow, complex immune response mean that managing these infections demands a sophisticated long-term approach, far beyond just administering a single dose of a drug. It's a continuous battle of adaptation between pathogen and host.
Finally, let's look at the global eradication effort for yaws. There's been renewed hope, especially with the success in India and the advent of azithromycin, but also significant hurdles that have pushed back the initial ambitious timeline.
This is a story of renewed optimism tempered by harsh realities and a race against microbial evolution. Buoyed by the truly successful elimination of yaws in India and the availability of that inexpensive single-dose oral drug azithromycin, the WHO renewed its efforts in 2012 to eradicate yaws globally by 2020. That was the initial ambitious target. However, based on the results of several pilot programs of Mass Drug Administration, or MDA, the target year for eradication will likely be extended. The initial enthusiasm has been significantly dampened by several critical factors, which are the main hurdles standing in the way of achieving this monumental goal.
What are these key hurdles preventing us from reaching that eradication goal, and what makes them so challenging to overcome?
First, pilot studies have indicated that a very high level of MDA coverage must be achieved. We're talking about incredibly high percentages of the population needing to be treated, requiring significant logistical effort, especially in remote areas with limited infrastructure. Furthermore, these studies show that multiple rounds of MDA are needed in the affected areas, not just one. It's not a single magical bullet. And even after mass treatment, it must be followed by careful case detection and targeted treatment of any remaining cases and their contacts. This isn't a one-and-done solution. It's a marathon of sustained public health effort.
And the second hurdle is that emerging azithromycin resistance, which we touched on earlier. This is a terrifying prospect for eradication, isn't it?
Yes, and this is a major, urgent concern. As we mentioned, azithromycin resistance has already emerged during the pilot study in Papua New Guinea. While subsequent treatment with benzathine penicillin G was able to contain the spread of these resistant organisms, such evidence strongly suggests that there may be only a short window of time during which countries can successfully rely on azithromycin for yaws eradication. Antibiotic resistance is a particular concern if multiple rounds of MDA are required, as it provides more opportunity for resistance to develop and spread, selecting for those stronger strains. Moreover, given the ongoing global campaigns against trachoma, another bacterial infection, that also use low-dose azithromycin MDA, often in the very same populations at high risk for yaws, more widespread macrolide resistance seems inevitable. This puts immense pressure on future strategies and means we are in a constant race against the bacteria's evolution.
And the third hurdle brings us back to the animal kingdom, doesn't it? That non-human primate reservoir.
Exactly. The third hurdle is the possible animal reservoir, particularly in Africa, which needs to be thoroughly evaluated. As we discussed, if wild non-human primates are indeed a reservoir for T. pallidum subspecies pertenu and can transmit it back to humans, it poses a fundamental, almost insurmountable challenge to eradication efforts. Because you can clear the human population, but if they can be continuously reinfected from an animal source, then true, lasting eradication is impossible without addressing that reservoir. It means the fight against yaws might not just be a human health issue, but an ecological one.
So what will it truly take for yaws elimination to finally succeed, given all these complexities? What's the bottom line for getting over these hurdles?
Yaws elimination will require rapid implementation and scaling up of high-level drug coverage in endemic areas. Beyond that, continued careful surveillance by local health centers will be absolutely essential for the success of this timely and important effort. Without robust, sustained surveillance, any gains made could easily be lost, as history has already shown us. It demands a holistic, long-term commitment that recognizes the adaptability of the pathogen and the complexities of human and animal populations.
This discussion of control really highlights how profoundly complex global health initiatives are. It's not just about finding a drug. It's about navigating logistics, understanding human behavior, battling microbial evolution, and even considering our intricate relationship with the natural world. The emergence of resistance is a stark reminder of the constant race we're in against these incredibly adaptable pathogens.
Precisely. It underscores that in microbiology, things are rarely as clear-cut or as simple as they seem at first glance.
Wow, what a journey. We've peeled back the layers on the endemic treponematoses, revealing how intertwined they are with venereal syphilis, and how much there is still to learn and achieve in controlling them. We've gone from their ancient history and traditional distinctions to the blurring lines of modern understanding, driven by cutting-edge genomic insights and surprising clinical findings that are forcing us to completely rethink old medical dogmas. It's a testament to how knowledge itself evolves.
And if we connect this to the bigger picture, the story of these diseases is a powerful reminder of how resilient pathogens can be and how critical ongoing research, vigilant surveillance, and adaptable public health strategies are. They really underscore that in microbiology, things are rarely as clear-cut as they seem at first glance, and that a deep, detailed understanding of every facet is paramount for those on the front lines, literally fighting these infections.
We've talked about the genetic similarities that make them almost identical, the surprising overlaps in transmission and age of acquisition that challenge old classifications, the distinct but often destructive clinical presentations, the profound challenges of diagnosing them when they all look alike serologically, and the critical importance of overcoming antibiotic resistance and that lingering crucial question of an animal reservoir for eradication efforts. It's truly a microcosm of the biggest battles in global health.
And consider this, for you listening. With global travel becoming ever more common and the unpredictable shifts of climate change potentially altering ecosystems and human migration patterns, these endemic diseases that traditionally stayed within specific geographic or demographic bounds might just be waiting for their next opportunity to surprise us in areas where they're currently non-endemic. What implications does this have for public health preparedness and vigilance in parts of the world that currently consider themselves free of these ancient yet incredibly persistent and adaptable infections? Are we ready for them to reemerge in unexpected places?
A truly thought-provoking question for you to mull over. Thank you for joining us on this deep dive. We'll catch you next time.